For the next 20 minutes or so, I'll discuss autoimmune hepatitis, how to treat the difficult patient. So I wanted to start off by just a few kind of background slides. First of all, looking at the prevalence and the epidemiology. So you can see that both genders are affected with autoimmune hepatitis, but predominantly women. And you can see that the incidence is slowly increasing over time, women much more than men. But I wanted to point you to the bottom where you look at the prevalence numbers, 25 cases out of 100,000. So autoimmune hepatitis, the prevalence in the general population is probably at most 0.025%. So that is really, really low. If you compare that to chronic hepatitis B, chronic hepatitis C, which could be as high as 5%, NAFLD, which could be up to 40% of the population, drug-induced liver injury. The point is that autoimmune hepatitis is a very, very uncommon, if not rare, condition compared to all other types of liver diseases. If you look at the age of a typical autoimmune hepatitis patient, any age can be affected, but you see it's bimodal. There's two peaks, one kind of the teen age and one right shortly after you retire. But again, women significantly more than men. And autoimmune hepatitis can present in a number of ways. It can present as an asymptomatic condition all the way up to fulminant liver failure. And most commonly, an autoimmune hepatitis patient will present insidiously. So there's very few symptoms. If they have symptoms, they're very nonspecific. They typically come to your practice because of abnormal liver enzymes. Less commonly, probably in about a quarter of the patients, they'll come in with an acute picture. So an acute hepatitis with jaundice, transaminitis. And about a third of the patients, by the time they present, already have established cirrhosis. But these are usually the older patients, the ones who have had kind of smoldering autoimmune hepatitis in the background for many, many years. So these are usually the older patients that come with cirrhosis. Now I point out these subclassifications, and we all have read about type 1, type 2, type 3 autoimmune hepatitis. But by far, type 1 autoimmune hepatitis is definitely the most prevalent. I would say in my practice, 99.9% of patients are type 1. In fact, I think in my 30 years of taking care and seeing liver patients, I have yet to see a single bona fide LKM positive type 2 nor a SLA positive type 3. And I remember when I was a fellow back at USC, my mentor, Dr. Telfer Reynolds, who had been seeing patients for over 50 years, once told us he has never, ever seen an LKM positive autoimmune type 2 patient. So quite frankly, in my opinion, type 2, type 3 autoimmune hepatitis, kind of like Elvis. There's been alleged sightings, but no confirmation. So I want to spend a few seconds just talking about diagnosis. Why is diagnosis important? Because I would say the vast majority of refractory autoimmune hepatitis patients that I've seen in consultation were not actually refractory autoimmune, but just misdiagnosed autoimmune patients. Remember, autoimmune is just a fraction of the population compared to NAFLD or drug-induced liver injury, which is by far more prevalent. So what is a bona fide autoimmune hepatitis patient? Well, autoimmune hepatitis is a clinical diagnosis, meaning there's no single test that says this patient has autoimmune hepatitis. It's a combination of different signs and symptoms and findings, but it's a clinical diagnosis. So first and foremost, you have to think about the demographics. Does your patient fit the demographics of an autoimmune hepatitis patient? Then we like to see other important factors like elevated IgG level, hypergammaglobulinemia. That's a very distinctive feature of autoimmune hepatitis and one we always look for. And then you have to have the autoantibodies, nuclear antibody, smooth muscle antibody. But most importantly, you have to have a liver biopsy. I don't think anyone can be diagnosed with autoimmune hepatitis without a liver biopsy, because you want to see that interface hepatitis. You want to see maybe an abundance of plasma cells. You want to see those characteristics on the biopsy that indicate that this is consistent with autoimmune hepatitis and not drug-induced liver injury or not steatohepatitis. So a liver biopsy is necessary in order to make the diagnosis. And most importantly, you have to have a good pathologist who you trust that you can review your slides with, because the distinction can be very subtle sometimes. But there's a simplified scoring system, and I put it up here, which has really helped me, but it points out the major issues. One, you have to have the autoantibodies. So if you have a patient that fits the demographics of a possible autoimmune hepatitis patient, you have to check the ANA and the SMA. Yes, you can check the LKM and things, but I don't think you'll ever find a positive LKM. You have to check the IgG levels. Do they have elevated serum IgG levels? You have to do a liver biopsy because you have to find that interface activity. And of course, you have to rule out all other causes of liver disease. Now, I dare say it's very, very difficult to make a diagnosis of autoimmune hepatitis in a patient when they have clear-cut steatohepatitis or they have clear-cut drug-induced liver injury. Because again, autoimmune hepatitis is a distinct diagnosis, which is almost a diagnosis of exclusion of other things. So you look for these different factors. There's a point system that's assigned to each factor. You can tally them up, and if they have 7 points or more, that usually means that this is most likely an autoimmune hepatitis patient. If they have 6 points or more, probable. So, enough about the diagnosis, but nevertheless, it's important to make the right diagnosis. Let's talk about the treatment of autoimmune hepatitis. So the goals of treatment are, 1, to get complete remission of disease, and 2, to prevent progression of disease. And as I'll discuss in just a bit, most patients with autoimmune hepatitis are going to require permanent maintenance therapy. So here's an algorithm. Say you've now diagnosed pretty confidently that your patient has autoimmune hepatitis. Not all patients with autoimmune hepatitis need to be treated. So clearly, if your patient has mild disease, so they have minimal transaminitis, on liver biopsy they have minimal interface hepatitis, they have no significant fibrosis, that's a patient that you could potentially watch. If you're going to monitor the patient, they should be monitored at least every 6 months. Optimally, they say quarterly, but I usually follow my patients every 6 months. Only if your patient has advanced fibrosis or histologic evidence of activity, so high interface activity score, do those patients require treatment. And if they require treatment, then you should proceed with what we call induction therapy. So induction therapy, or first-line treatment for autoimmune hepatitis, is very, very effective. Autoimmune hepatitis is exquisitely sensitive to corticosteroid therapy. So induction therapy starts off with moderately high doses of corticosteroids, prednisolone or prednisone. And actually, I'm talking about prednisone, 30 milligrams a day is sufficient to really start to quell the effects of autoimmune hepatitis in almost all cases. But these patients are exquisitely sensitive to corticosteroid therapy. And then you start azathioprine, usually within 2 weeks of corticosteroids, but you typically wait until the bilirubin has settled down below 6. But there's no reason why you couldn't really start azathioprine simultaneously with corticosteroids if you want, because azathioprine will take a few days to start kicking in. And if you're confident about the diagnosis, there's really no reason that you can't start azathioprine at the same time. But this is first-line therapy, and as I mentioned, in autoimmune hepatitis, almost all patients will respond very nicely to induction first-line therapy. If the patient doesn't respond to first-line therapy, most likely the diagnosis was wrong. And I'm talking about a lot of patients who come in with drug-induced liver injury, misdiagnosed as autoimmune hepatitis. They don't respond well to induction therapy, but in most cases, the patients will respond very well. You may have to evaluate them for treatment adherence, but in general, the major cause of non-response to induction therapies is just really a misdiagnosis. So what is the aim of the treatment? The aim is to completely normalize the transaminases and to normalize, decrease the IgG levels. And this is called biochemical remission. And a patient should be kept on treatment for at least 3 years or at least 2 years following complete biochemical remission. Now, there are patients, I usually tell my patients autoimmune hepatitis is a chronic condition and most likely you're going to require treatment lifelong. But there will be patients that want to come off of therapy. And so if you are thinking about discontinuing therapy in a patient who has achieved biochemical remission, then it's important that you do a liver biopsy prior to stopping treatment. Because not only do you want biochemical remission, you want histological remission. So you have to do a liver biopsy to ensure that there's no underlying interface activity before you discontinue treatment. If you do the biopsy and the patient still has activity, interface hepatitis, then unfortunately you're going to have to tell that patient we cannot stop therapy. So the goal of maintenance therapy, keeping patients in biochemical remission, ultimately and optimally is to get them onto monotherapy, preferably with azathioprine, and to come completely off of corticosteroids. And in most cases, you'll be able to achieve that. There will be some cases where you may have to bump the level of azathioprine up just a little bit. 50 milligrams a day is usually the typical dose. But unable to get a patient off of corticosteroids completely, you might have to increase the azathioprine just a bit, and that's okay. Alternatively, there are some patients that will just always require even a low dose of corticosteroids in combination with the azathioprine in order to keep biochemical remission. So it's not uncommon, and I have a number of patients who require azathioprine plus maybe 5 milligrams of prednisone on top, and that's fine. Low dose corticosteroids, if needed, would be fine. What do you do with those patients now who are refractory to corticosteroid therapy? So despite you start them off on moderate to high dose corticosteroids, but you're never able to bring the steroid dose down without their transaminases starting to increase again. Well, if you have a patient that's truly refractory to corticosteroid taper, your alternatives usually are using mycophenolate mofetil or probably a calcineurin inhibitor like tacrolimus or cyclosporin. Now, there are other alternatives that you can consider that have been listed, such as infliximab, cyclophosphamide, methotrexate. But these are really not studied well. There's very little in the literature about these. And if you decide to use one of these drugs, you're really venturing into uncharted territory. There's not a lot of guidance or experience with these drugs. So you're mainly left with a second line therapy, mycophenolate or the calcineurin inhibitors. So here's a study just looking at cyclosporin for a steroid-resistant autoimmune. And you can see this is a study actually at Cedars-Sinai by Dr. Fong and his group. They looked at 5 patients. And you can see in these steroid-resistant patients that on cyclosporin, they were able to achieve biochemical remission as far as transaminases and bilirubin in most of the cases. So you can see that cyclosporin can actually be fairly effective. But again, most of the literature is small numbers, so they're no large controlled studies with cyclosporin. Similarly with tacrolimus, this is a study of 7 patients, and you can see that after starting tacrolimus, the transaminases improved. You can see that the patients were able to come off of corticosteroids, and you can see looking at the paired biopsies that the interface activity improved on tacrolimus. So this is another alternative, but again, there's not a lot of data out there, not a lot of big, large controlled studies, but more kind of small series case reports. Mycophenolate, this was a study of 59 patients who were given escalating doses of mycophenolate. And you can see that they were able to come off steroids. And then within about 6 months, most all of the 59 patients were able to achieve biochemical remission. And of the patients that made it out to 5 years follow-up, this biochemical remission was sustained. So mycophenolate is also another possibility. Now, the problem with using calcineurin inhibitors, mycophenolate, is you now introduce a whole new set of side effects associated with these drugs. So with the calcineurin inhibitors, you have the possibility of nephrotoxicity, neurotoxicity. Mycophenolate, you have issues with neutropenia, things like that. Mycophenolate also is teratogenic, so you can't use it in women of birth of a young age if they're thinking of becoming pregnant. So corticosteroids have a lot of adverse effects, and as you can imagine, in that case, you can consider using budesonide. Azathioprine has very few side effects in general, but if a patient is intolerant to azathioprine, then mycophenolate is recommended as alternative therapy. So let's look at our little algorithm here. If you have a patient who you've now had in biochemical remission for a period of time, you can try to stepwise decrease the immunosuppression. Remember, you may have to do a liver biopsy to document, to confirm that they have no underlying interface activity before you stop treatment. And if they meet all these criteria, you can possibly stop therapy. And if they're able to maintain biochemical remission, that's great. You should continue to follow the patients regularly. But if at any point they relapse with transaminitis, jaundice, then you have to restart induction therapy, get them back into biochemical remission. And then these patients, having failed to come off of immunosuppression the first time, are now pretty much destined for lifelong treatment. Treatment withdrawal is plagued with relapse. I think in general, most patients, upwards of 90%, will relapse with time. And this graph will show you that the percentage of patients remaining in remission will slowly drop with time. So ultimately, taking a patient off immunosuppression these patients are prone to relapse. And so this is why I go back to my first statement saying that in a patient with autoimmune hepatitis, they will most likely require lifelong maintenance therapy. So this is my last slide just to show you the treatment algorithm. If you have your patient, you diagnose them with autoimmune hepatitis, you start them on induction therapy with corticosteroids. If they have a good response, you add in azathioprine, and then you taper the steroids, and then you maintain the patient on optimally azathioprine monotherapy. If they're azathioprine intolerant, you can consider second-line therapy like mycophenolate mofetil. If the patient does not respond to induction corticosteroids, my advice is you have to seriously reconsider the diagnosis, because in most cases, the diagnosis is wrong. Once you make the correct diagnosis, you can treat, and the patient should hopefully get better. If the patient does truly have issues with non-compliance, you can scare them by increasing their corticosteroids to a higher dose. This usually results in a good response, and then you can start azathioprine and then get them onto maintenance therapy. If a patient is truly, truly refractory to high-dose corticosteroids, then you may have to consider some of the more difficult agents. And at this point, it's probably best to have the patient seen at a specialized center for other therapies. So with that, I will end. Thank you very much.